Welcome everyone to, I believe, our third seminar of the semester. And today we have Dr. Chethan Sarabu, Clinical Assistant Professor of Pediatrics at Stanford University. We actually connected in the spring via, interestingly, Amy's Climate, Health, and Informatics working group was connecting with the 25x5 group and discovered there would be a lot of wonderful things that we could learn from you at our seminar. So Dr. Sarabu is trained in landscape architecture, pediatrics, and clinical informatics, builds bridges across these fields to design healthier environments and systems. He's inaugural director of clinical innovation for the Health Tech Hub at Cornell Tech's Jacobs Institute. Over the past 6 years, he's been a clinical assistant professor of pediatrics at Stanford, and has worked in the health tech industry as head of product, director of clinical informatics, and medical director at doc.ai and later Sharecare. He collaborates with the OpenNotes Lab as an AI and Informatics strategist and serves as a board member of the Light Collective. And today we'll be talking about patients and clinicians at the heart of health innovation, OpenNotes Lab and Cornell Tech Health Tech Hub. Thank you. Welcome.
Thank you so much. It's really great to be here with all of you today. I was just thinking, since it's not too big of a group, it'd just be great to learn who's in the room. So if just want to briefly just introduce your name and your position and maybe one brief thing about what you're excited about or work on in informatics.
So I'm JV, I'm a fourth-year PhD student, and I work on like cancer immune interactions on the bio side of things. Yeah, pretty excited to start.
So I'm a first-year PhD student. So I'm working on the clinical notes and clinical elements.
Excellent.
Hi, I'm Adrienne Pichon. I am a very senior PhD student with Dr. Noemi Elvegad, and I work with patient-generated data with endometriosis.
Oh, excellent.
My name is Young. I work in multimodal learning in the context of clinical informatics. The question of what types of modality helps and when.
I'm Opera. I'm a third-year PhD student, and my work focuses on fairness and equity in machine learning, particularly in psychiatry.
Hi, Harry Reyes, another PhD student almost graduating. And the focus of my work is on leveraging computational methods to advance health equity science.
I'm Celine. I'm a first-year computer science PhD, and my research focuses on the uncertainty quantification of some foundation models on HIV.
I'm James. I'm a first-year PhD student. I'm focused on LLMs in a clinical context and evaluating them.
I'm a first-year PhD student audit. And I do work in like hospital record data extraction, more in like the oncology space.
Excellent.
So my name is Lisa. I'm also a second-year PhD student. I work on famous.
I'm Cindy. I'm an MD PhD student, technically fourth year in the program, but a second year in the PhD. And I work on observational data research.
Excellent.
And I'm Kayla. I'm a fourth-year PhD student with Dr. and Precision Labs, Claribies. And I work on clinician decision making for empirical care models.
Hi, I'm Sarah Rossetti. I'm an associate professor in the department. I work in clinical informatics, problems mainly in the hospital setting, things such as implementation of AI for early warning systems, analysis of nursing documentation, and reducing documentation burden.
Excellent. Well, really excited to be here with all of you. I think my talk will touch upon some of the different themes that are being explored today, maybe go into some different directions too. So yeah, excited to share with you all. Okay. So as you can see, I kind of have this complex series of roles that have across academia and industry, but really kind of the top row, that's my primary kind of time right now. So I'm primarily at Cornell Tech as a director of clinical innovation, really helping to bridge, and I'll talk more about this later, the dots between the tech side of healthcare and the clinical side. And that I think also, it's not just limited to collaborations at Weill, but could be to Columbia and health systems across the city. I also work in climate health, and then what I'm going to be talking to you about mostly today is the work I do with OpenNotes. I'll just go through. Just also had shared some of the kind of my early work in OpenNotes. Really started with, and I'll talk more about it, but really started with a lot of publications around pediatrics and OpenNotes of looking at the intersection of transparency and health information, but looking at these more vulnerable populations and some of the issues of adolescent confidentiality and how that fits in. And it's not just a pediatric issue, but really across the board when it comes to information that's shared with patients, but also their caregivers. I've also done a lot of work more from the startup side of developing different AI models. A lot at this startup called doc.ai, which then got acquired by Sharecare, but really a lot of early research in computer vision based models. On the left was a tool for detecting ptosis, eyelid drooping in patients with myasthenia gravis, a rare neurologic condition, and trying to build models that can predict that. But my work is kind of, it's really about bridge building and spanning these different disciplines and connecting the dots. So today I'm going to talk to you primarily about OpenNotes, then the OpenNotes Lab and AI. Briefly touch upon climate health informatics, particularly in the context of the environmental footprint of AI. And then finally, just a few comments on my role at Cornell Tech and maybe some opportunities for collaboration. Really quick, how many of you here have heard of OpenNotes? Okay. I will be happy to share more then, that is. So OpenNotes is an organization that started really to pioneer transparency in healthcare. It's a nonprofit organization that started at the Beth Israel Deaconess Medical Center in Boston, one of the Harvard teaching hospitals. And it's started in 2010 and really was about this very simple question of what happens when patients get full access to their doctor's notes, to their clinician's notes. It was a pretty radical idea at that time because since HIPAA was passed in 1996, patients did have the right to request their medical records, including their notes, but very few people did. Health systems often put up a lot of barriers, like you had to pay to get printed copies or you'd get a huge PDF. But as we started to implement EHRs, and we had patient portals, there's this question of, it doesn't cost the hospital anything to provide that electronically to patients, but it was a big cultural shift. And so that was really kind of the origins of OpenNotes, and over a decade of research has really shown that it's been something that's really beneficial for patients. It's made care safer because when patients have access to their own notes, they're able to spot errors or issues that may have gone unnoticed otherwise, because patients often they have the greatest interest in their own health and health information. And so that's really kind of the origins and record of OpenNotes. Just to walk you through a bit more of this timeline. So launched in 2010 with this initial study with 20,000 patients. The study was a success. Patients really found in this year-long survey that with like 96 to 99% of patients reported that having access to their information greatly increased their ability to understand their care, to remember what to do. And many of the fears that clinicians had, such as patients may not understand the notes, it may cause more harm than good, were really unfounded. And this is maybe jumping ahead a little bit, but there was just an article in the New York Times this week about transparency around AI-based messaging to patients. So many health systems, you're probably aware, have turned on the ability for clinicians to use GPT-4 directly in Epic to draft a message to patients and then send it to them. The vast majority of health systems do not tell the patient that AI was used to generate it, under the caveat that a clinician is reviewing the message and it's ultimately the clinician still sending it. However, some health systems have put in a little notice saying that this message may have, is generated with the assistance of AI. And there's some CMIOs who've said they feel that the disclosure of AI being used could be more harmful than helpful. But I think that's a subject of that's a pretty provocative point. And so just kind of wanted to connect those dots there, and I'll get more to this work in AI, but it really all connects back to this question of transparency. How much are patients told about what's going on with their care and their information? And so a lot of the early work of OpenNotes, really from 2010 to 2020, was expanding access to notes because it was not required by law. It really was just individual institutions turning it on. A lot of my work at Stanford as an informatics fellow was launching OpenNotes at Stanford Children's, one of the first pediatric implementations. And since that time, then when we get to 2021, the 21st Century Cures Act goes into effect, and it's now federal law that patients have to have access to the records, and the vast majority of the population does. There's some exceptions. They also put in, it was the same time that the AMIA 25x5 documentation burden reduction initiative launched as well, because I think, you know, they're all kind of parallel questions around documentation, and we'll talk a little bit more about that. And then OpenNotes has continued to work on with new initiatives, including the OpenNotes Lab that I'll talk more about later. And really, you know, this is basic information, but we know that the medical chart contains all of this disparate information, but it's really the notes that often bring everything together. And notes are interesting because they're not necessarily just a direct recording or transcript of what was talked about, but it's often a clinical interpretation of a conversation. And there's a great deal of variability. So from this example, a mother might have said, my son Johnny has not been feeling well. It's been really hot for the last day. He was shaking and then it stopped. A clinician may interpret that to be a febrile seizure, a seizure caused by a fever. But it may not be that. It could be something else, and maybe they didn't ask more questions. But then, you know, the documentation may just say patient appears to have had a febrile seizure this morning. And this has been, you know, I think the long history of documentation of understanding that interpretation, information may be lost. And I think with AI-based ambient scribing, where you're able to record conversations and capture documentation, there's a lot of new interesting areas of exploration happening at this interface. This idea of documentation goes all the way back to, you know, early ages of medicine. This was, you know, a quote from one of the, you know, older figures in medicine, also the idea of documentation is really observing, recording, tabulating, and communicating. And notes have taken these different forms. You know, they used to be on paper. Then we got to electronic notes, and they both have their pros and cons, where with paper notes, it may be harder to read what someone said. But one of the issues with the electronic notes is it became a lot easier to make them much longer. You can just put in a whole bunch of stuff so that the information that you need may be lost. So there's this whole question of, we focus a lot from the health system on the burden of creating documentation, but there's very little in terms of system influences that look at reading and understanding documentation. And we have all kinds of notes, and this may all be pretty obvious to many of you, but there's notes written by physicians, nurses, social workers, students, notes in outpatient, inpatient clinic, in the operating room. There's different types of notes based on where you are with care, and there's different formats for notes. So even though we have this concept of note, there's many different types, and data standards like the US CDI, US Core Data for Interoperability, has been trying to create more standardization and structure around this. But they're still, you know, they're fairly heterogeneous document types. Generally, they may have these sections and divided into subjective, objective, assessment, and plan. The SOAP note's one of the most common formats. But the thing about notes is that they have many different audiences. They are for the clinician to remember what they had talked about for future visits. On the top right, to communicate with other clinicians. So maybe your primary care doctor who's referred a patient to a specialist, and now the specialist needs to know what was discussed before. But then on the bottom, you have, you know, notes are the primary piece of documentation used for billing, and it's the legal record. So they have many different audiences and purposes. And I think one of the challenges of notes has been trying to be a little bit of everything to everyone. And that sometimes leads to things where, from a billing perspective, a hospital may say, hey, like add all this like additional detail so we can check the boxes and maximize how much we can bill for this. But that may actually come at detriment from clinical reasoning because there's maybe just a lot of extra text, and being able to read and process that presents an additional cognitive burden. So there's all these trade-offs between trying to make notes work for all these different purposes. And then also, what about patients, right? It's important for patients to be able to remember what their clinician recommended, understand their reasoning. It's their right to have their information, and important from a safety perspective to review and be a voice to look for errors. And so this is where OpenNotes came in. I won't, this is the initial study that happened across Beth Israel, Geisinger, University of Washington, and Seattle. And basically, over a decade of research have found all of these different benefits. I'll highlight on the accuracy and safety some studies that showing patients have found like 25% of patients who read their notes in studies find errors. There's another study which showed about like 9 to 10% of those errors are actually really serious safety issues that needed to be addressed right away. So it's important from that perspective. There's one study that showed from an adherence perspective that patients who can see their notes are actually more likely to adhere to the treatment that's recommended. There's some newer studies too that shows having access to the notes and patients who read them are more likely to close the loop in terms of following up on if your doctor recommended you need to go get a test or see a specialist, you're more likely to do that when you have access to those notes. So a lot of benefits over a decade of studies across multiple clinical specialties. And so, and yeah, sorry, I meant to remove the animations, but this is going through some of the same stuff. Yeah, so after that, basically then 200 health systems around the country started to implement OpenNotes, over 100 publications across many different areas, including mental health. There was an early OpenNotes study that actually looked at releasing psychotherapy notes to patients at the VA, which is often like a pretty protected type of note, and a lot of questions around how that may affect therapeutic relationships, and found to be beneficial in the broad strokes. But also have dove into some other areas. In the bottom, you'll see open test results. In addition to notes, patients have access to their lab results. And that brings up some questions of like, if patients haven't had a chance to talk to their doctor and they see in the portal that there's a lab test or radiology report that says something concerning, like you may have cancer or cancer has occurred, but you haven't had time to contact the doctor, there's open questions around that the OpenNotes team has been studying as well. And then really from 2020 to 2023, it's like kind of the policy years because the Cures Act final rule went into effect, and there's been these additional projects kind of like Our Notes and Our Diagnoses, which are really around the idea of collaborative documentation where patient is also part of creating the documentation, and also part of the diagnostic process. And all of OpenNotes' work until this point has been funded purely by nonprofit organizations, foundations, really had not been working with any commercial interests. And then in 2024, I was brought on to the team to help launch the OpenNotes Lab, and we'll talk more about that. But basically, as we start to see the rise of AI and other emerging technologies in documentation and patient-clinician communication, brings up all of these questions, right? Like how might these technologies be used directly by patients in their ability to engage in care? As AI transforms interactions between clinicians and patients, how do we ensure that it still continues to build trust and understanding? Wanted to share a story there that I heard recently from a patient panel we were a part of. There was a patient who was communicating with her clinic through the portal with a nurse named Jessica, who was like really responsive. And the patient, when she went to the clinic, went to the front desk and said, "Hey, I really want to thank Jessica. She's been an amazing nurse." That's when they revealed to her that Jessica was an AI chatbot and not a real person, and that was never disclosed to her. And she felt upset by that. So, we're starting to see AI, particularly LLMs, be implemented in direct patient-facing applications very rapidly in healthcare compared to sort of historic norms for how new technology gets rolled out. And so on the bottom, I know a lot of you are interested in equity and algorithm design. So how might we ensure that these algorithms are trained and implemented in ways that respect the diverse needs and rights of individual patients and their clinicians? So these are just some of the guiding questions that we sought to ask and answer. And so that's the launch of the OpenNotes Lab. And this is our core team. So Kate DeRoche is the executive director of OpenNotes based in Boston. And Amanda is the deputy director of the lab, and Liz is the communications and patients initiative director. And then I work part of my time with them as an AI and Informatics strategist. And we're starting to see, pointed out some of these examples about what generative AI can do with documentation. There's this, a lot of hype around what's possible, but it really does feel like a breakthrough technology. When you look at what the technology is able to do, what the clinical needs are, and what the business needs are. So I think that alignment has really led to a lot of great use cases by health systems. And so there's all sorts of projects that you've probably been seeing, some of you may be involved with, and not just, physician documentation or nursing documentation, but being able to take something like a discharge summary and translate it to more patient-friendly language. Or there's been some papers on taking consent forms that patients have to sign before a procedure, using LLMs to explain that in more simple terms. And there's also, there's a lot of the focus from the research community and the informatics research community has been in generative AI use cases by health systems directly, but there's also a lot of work happening in patient communities where patients are using AI on their own for different things, like trying to work with insurance companies or billing departments, trying to get a second opinion on their care when they weren't able to reach anyone else. And so there's a lot happening at this intersection. I was recently I can share a link to this, but was recently at the AI and Healthcare Forum at HIMSS in Boston, was able to share really a lot of these patient perspectives, and there's a video they have recorded about it. And so, sorry, I really meant to take the animation out of this one, but kind of where we're looking at with the OpenNotes Lab, just to frame, there are AI tools being deployed all across the board for different aspects of clinician-patient communication. But if you put it in context of an outpatient visit, there's some tools that are being used before a visit, like pre-visit questionnaires that are powered by an AI chatbot. During the visit, ambient scribing. After the visit, tools to help clinicians more rapidly finish documentation, help patients understand their notes, and more tools between visits for communication. So these are just some of the areas that we've been kind of working on, and the work we do is to develop AI technologies through a patient lens. I should really say co-develop. We're not technology developers, are really a research group with a lot of patient and research experience. But for the first time with the OpenNotes Lab, we are actually working with for-profit AI companies as a co-design partner. And so we haven't publicly announced some of those partnerships, but we hope to soon. But so that's some of the work we're doing. We're working with health systems to better evaluate AI tools for patient centricity, working with health systems on the guidance of AI tools in healthcare settings, and providing lenses of what patients would ideally want to see, and then ultimately informing policy, legislation, and regulation around health AI through a patient-centric lens. So that's really the kind of goals of the OpenNotes Lab. And I think I shared this already. We're seeing kind of just, I think generative AI has really connected the dots in alignment across multiple forces, helping patients grow their agency and autonomy. And then with the 21st Century Cures Act and more access to information, patients now have all of their notes in labs. And now generative AI is a powerful tool to help make sense of that. Obviously, there are a lot of caveats and concerns. There's issues of hallucinations and how you prompt a particular system can give you vastly different output. So we do have some work studying patients' direct use of LLMs to understand their notes that we'll be able to, we're working on a couple of studies on. And I think health systems are also, really, as they implement this, there's a lot of questions on how you validate AI-generated summaries. What does it mean to keep a clinician in a loop? In that example of physician-reviewed AI-generated messages, there's this very well-known fact of automation bias, where if in the beginning, maybe you're very vigilant about reading everything that AI writes, but if you're like, this looks good 95% of the time, you may start to lull yourself into a kind of false sense of security. And then there's all these questions of the liability balance. Right now, the clinicians are taking on all the liability, but there's also implementations of AI tools where AI companies are sending information to patients without clinician review too. So there's a lot of open questions about what that means. And this was a study that you might have seen where there was a mixed method study of primary care physician perspectives, really looking at how they understand what AI tools are doing. And obviously AI is such a broad term, and I think a lot of people who aren't as technically focused or in the loop may start to really gravitate towards thinking of AI as just ChatGPT and LLMs. But obviously there's all these different use cases of what AI can do. And I think there's a rapid kind of education and workforce training from students all the way to, clinicians who've been practicing for a long time, really getting up to speed about what all of this means. And we have these different coalition groups like CHAI, the Coalition for Health AI Partnership, RAISE is an initiative at Stanford, Responsible AI for Safe and Equitable Health. And I know there's probably others. I think CHAI and Health AI Partnership are sort of emerging as like the two kind of leaders in the space to be able to provide industry-wide best practices, guidance. And we think, it's important for patients to be part of this conversation as well. Forgot to include a screenshot of this, but I'm a board member of this organization called the Light Collective, which is a patient data rights organization. And we created this patient AI rights initiative. And we've worked with organizations like CHAI and Health AI Partnership and being able to provide more of the patient-centric lens there. I'm gonna skip that part. So yeah, so all of that to say, just this summary slide with the work of the OpenNotes Lab, we are, co-developing AI technologies through a patient-centric lens, evaluating tools for centricity, guiding best practices, informing policy. So I'm gonna switch gears a little bit, but before I do that, just wanted to pause and see what questions or comments about this, and happy to dive into different directions. Yeah.
Great, thank you. Very interesting stuff. I was actually in Boston when the whole OpenNotes thing started, so it's crazy to see how far it's come in this time. My question is about the types of patients you're seeing that are using OpenNotes, and in particular, I'm wondering about the digital divide and differences in digital and health literacy, as well as literacy in general. And maybe any barriers you've identified or tried to overcome to try and get different types of patients engaged.
Yeah, it's really key question. There have been some studies that have looked at, I know, for example, when OpenNotes was implemented in the LA County system, where the vast majority of patients were non-English speakers, primarily, there's a lot of questions about how helpful the notes would be, because notes are still in English primarily. And I don't have like the specific details from the study, but I remember anecdotally, they had shared that it was still very beneficial for patients, because often patients with limited English proficiency, even when a health system uses a translator, that there's likely to be more of an information loss during that visit. But then a lot of people with limited English proficiency may know someone in their life who is fluent, and the ability to then have that note that they can share with someone who is actually really helpful and an important equity issue. There are definitely a lot of digital divide issues with the fact that patient portals are still a bit clunky, requires a certain level of, technical savvy to be able to log on, access that information. And I know there was actually this OpenNotes New York State collaborative where they had almost, I think it was 20 health systems throughout New York State that were primarily federally qualified health centers throughout New York City and upstate, where most of the patients had, that there was more of a language barrier or a bit more of a digital divide or socioeconomic challenges where of where these clinics work, and basically had a year-long process of having all these clinics throughout the state kind of share best practices of how to help their patient populations make the most use of their access to their notes. So I'd say like those are some of the things that have happened, but I think definitely more has to be done. I think the interesting question with AI is now the fact that you can take your note. I mean, you could do this with Google Translate, but there's questions of like how well it works and how much kind of context you can add at once. But a lot of work now on being able to just translate your note to different languages, to different, levels of reading comprehension. I think that's an important equity, an important tool in making healthcare communication more equitable, because health systems have had translators for verbal communication, but for most written communication, we haven't really had scalable ways of translating language.
A couple questions on Zoom as well.
Okay. Do you mind read? I don't know if I can, for some reason I'm not able.
Courtney, do you want to go ahead?
Yeah, hi. First off, thank you so much for a wonderful talk thus far. It's been really engaging and awesome. I'm one of Sarah Rossetti's students, so I'm also very interested in documentation as it happens. And particularly, referring back to your slides, I think it was like 31 or 32. It was the breakdown where you had the different roles of how you envision, or how OpenNotes envisions AI and the doctor and the patient all working together. So yeah, I think it was a slide right before this. And I'm very interested in, oh yeah, this is it. So I'm very interested in, I noticed in the after visit, particularly the distinction between the clinician being the one to write the note and the tech or AI, quote unquote, helping clinician write the note. So I'm really curious, how are we determining what writing the note versus helping write the note actually looks like? And what's that like, how are we defining that threshold basically of how much the clinician needs to be involved versus how much the AI needs to either be, an auxiliary feature or a primary feature? Like, how do we delineate that, and like what's being done, I guess?
Yeah, such a good question. It's really kind of at the heart of this. So and you think about what's written in the note, there's a certain portion of it that is typically more verbalized as part of the conversation between patient and clinician. But there's also a component of the note that isn't always verbalized out loud, which is the clinician's reasoning of why they might think treatment A should be recommended over treatment B, or why they're thinking of like one diagnosis over the other. And traditionally, clinicians haven't necessarily verbalized it. There's a conversation, and then when they go back to write their note, they may put in more of their clinical reasoning, but that isn't always necessarily shared with the patient. Interestingly, now with AI scribe companies entering the fray, their recommendation often is for clinicians to be more transparent with all of their thought process, so that the scribe can pick up all of their thinking and better incorporate that. And so that's like another interesting aspect of this to consider in terms of how much is coming directly from the conversation versus how much is coming from clinical reasoning. There's obviously other parts of the note, like the physical exam, reviewing lab results, that need to be more manually brought in, that an automated scribe may not be able to do. But ultimately, there's still all these questions. There's about probably 5 prominent companies, but over a dozen companies that have these AI scribe tools, and they all have different models and thresholds of what they think is important in a conversation. And the AI is listening in and generating a pre-note that then the clinician is reviewing. But I'll share an anecdote. I won't name which AI scribe tool this was, but this was an anecdote shared by a pediatrician at the HIMSS forum. They had a visit with a 3-year-old and their father, who the 3-year-old was having a lot of behavioral issues, and they're talking about a lot of like dynamics around the home and school. Had a 30-minute conversation about this, and then the AI scribe tool, when it generated the note, the note was only 2 sentences long. And it basically deemed that the vast majority of the behavioral issues at home and school were not clinically relevant. And that, indicates to me one of the issues I talk a lot about is pediatric care. The type of information that is important is often very different than what is in adult care. And so if these models aren't really trained with good pediatric data, then they're not going to perform as well. I don't know if that's the reason that didn't perform that well there. But then this pediatrician was frustrated by this, and they basically had to write their own note, thinking that the tool was writing it. And interestingly, the father of the child was actually an engineer at the company that built the scribe tool as well. So yeah, and another aspect I'll bring up, this is a conversation recently with Kurt Cole. He's the CIO for Cornell, you may know him. Kurt has been bringing up this issue of, if clinicians start to feel like they don't really need to remember the details of conversation as much because the AI scribe is going to do it, is it going to change the way they're thinking during a conversation? Are you being as vigilant about picking up on the details? But we don't know. Maybe you can actually open things up, because if you don't have to worry about remembering every detail, maybe you actually listen more and pay more attention. So I think there's a lot of open questions about that. So yeah, thanks for bringing that point up. And there's so much more to say on this. I think to your question, how much is written by the AI, how much is written by the clinician? There's also a question, if you're going from an AI generated summary that then the clinician is writing, does the patient get the right to review the AI generated summary to make sure what they said was accurately represented too? And that's kind of an open legal question right now.
Yeah, I'm taking a qualitative class right now, so I'm really thinking about this from is this more of a qualitative descriptive where the note is just, and the scribe is just meant to be this passive collector of objective data, and then the interpretation is up to the clinician. But it sounds like we're trying to move in the direction of maybe the AI scribe has more interpretive responsibilities. And so I think it's a really interesting dynamic, and asking a patient to review or allowing them access, kind of acting as like member checks, basically, like, did the AI get this right, is a really interesting concept. So thank you so much.
Yep.
There's like 3 more questions in the chat. Do you want to answer them now or wait till the end?
I'll do one more question, and then I'll maybe just take the last part of the talk shouldn't take too long. Just wanted to bring up a few other ideas, but I can take one more question.
Rita?
Thank you for.
Can't hear you.
You can't hear me? Is this better? How is that?
Rita, if you want to write in the chat instead, and then Bettina, I'm gonna answer your question.
Okay, I have to get, okay, let me write it in the chat.
Sure, yes. Well, yes, thank you. So it's incredibly exciting to hear about all the innovative developments happening within OpenNotes. So just a quick question. I think you mentioned briefly earlier about clinician training, the need of that. And I am just curious if we could talk a little bit more about the, what is your approach to training clinicians integrating this Gen AI within OpenNotes platform?
Yeah, it's a really good question. So I think I hinted at this, but didn't really talk about it. It was on the timeline slide. So OpenNotes in concert has been doing a lot of work, primarily through Harvard Medical School, of student, health profession students' education on documentation in a patient-centric lens. And there's actually a book that was published on this recently too. And then I think this is still not public yet, but I think it's okay to share. I think I had it on this slide. There's work to launch the OpenNotes Academy, which is really around education, around documentation, and it's, you know, best practices from the decades learned of what of patient-centric language, but also really looking at how AI is starting to transform documentation and the education that's needed to best support that. So I think I'm not as directly involved with the education work, but if that's an area of interest, I'm happy to connect you with some of the people who are leading some of that too. So thanks.
Thank you.
All right. Was Rita's question in the chat or?
Not yet, but we can-
Okay, all right, I'll just quickly go through the rest of this and then hopefully still have more time. Briefly, just wanted to talk about this idea. So there's a lot at the intersection of climate change and health, but one of the topics that I've been really raising a lot recently is looking at the environmental footprint of AI. And with healthcare being such a large industry and a large adopter of AI tools, I think it's important that we consider this in all of the excitement. We're starting to see all this information about how much training models running AI is exhausting the power grids, the water that's used. Some studies show like one ChatGPT search is about the same amount of energy as one search on Google. Some say that it's almost 20 Google searches. Sorry, yeah, one ChatGPT search is about 10 Google searches of energy. You can see just some of the information about the amount of energy and stringing the grid. I was just in Climate Week last week, part of this Axios panel talking about these issues, and I had talked about some of these points, and they were picked up in that discussion. And we have a little bit of information from a few of the more open source models of how much energy it takes to train these LLMs. But there's still a lot that we don't know as well. But we know that there's a lot of variability in terms of the data center that's used or choice of architecture that can really cause huge variability in that footprint. There's a couple of different organizations and papers in trying to understand best how to align AI with climate change priorities. We had this at Stanford. We've been doing a lot of work around healthcare sustainability and the EHR, both in terms of how the EHR can nudge greener care choices, but also looking at the footprint of health IT itself. This is from our FAMIA presentation last year, looking at there's a lot that informatics can do to help clinicians choose greener options, but we also have to look at the footprint of LLMs, all of these data-driven technologies that we're rapidly rolling out. And so this was some back of the napkin calculations, trying to figure out how much increased energy use would happen from an AI-powered messaging system for like a medium-sized hospital. Need to do a lot of validation of these numbers, so don't quote me on this, but you know, we found that a medium-sized hospital that implemented a like GPT, I think it was GPT-4 that we used, messaging system for most of their clinicians to patients, that may add an increase of 2.3% electricity demand of the hospital's overall use. Obviously, there's a lot of questions of like, you know, is the model being run by the hospital? Is it from a cloud provider? Where's the energy source coming from? But these are all questions that I think we need to keep in mind as we come to grips with all of this. And there's maybe a lot of different strategies around this. And this is part of a broader field of climate health informatics, looking not only at the sustainability side, but also really connecting the dots of how do we use environmental information to better predict like someone's risk of asthma in relation to air pollution, for example. And I won't go into all the details of it, but there's a lot of different informatics opportunities. On the right, we started at AMIA, the Climate Health Informatics Working Group. If you're at the AMIA Annual Symposium this year, we have multiple events and talks on it. I also co-founded this organization called Chill that really is more of a newsletter, and we have events and helping to connect the dots around this. And so, yeah, and then just really briefly, I know I'm like jumping around a lot, but just to kind of give you a sense of my role at Cornell and where there may be some collaboration. So this is the Health Tech Hub at Cornell Tech, which is really formed last year to connect all the different health tech initiatives. So we have a lot of researchers across many different areas of more like deep technology, from robotics to augmented reality to machine learning to optimization. And so there's a lot of researchers across the board. We also have a lot of startups in the health tech space that have come out of Cornell Tech. And really we've been working, we have this conference called Health Next, which comes up in the spring, really trying to connect the dots and grow New York City's health tech innovation ecosystem. And it's not just, you know, we're driving this from Cornell Tech, but we really see this as an all of New York initiative. And this is just some mapping I've been working on of like where Cornell Tech and Weill and New York Presbyterian and Columbia and all these different initiatives may start to come together. So I'm not going to dive into this in detail, but I will say I spent the last 7 years in Silicon Valley at Stanford and the Silicon Valley health tech ecosystem, which I think is still considered the #1 place based on the amount of dollars and startups. But New York is #2, but I think in many ways is much richer. There's a much greater diversity of perspective and people working in healthcare technology, informatics. Not to make it a competition, but I'm personally very bullish on the future of where New York is going here. So with that, just wanted to thank you for your time and happy to answer more questions.
Thank you for touching on like climate and LLMs. I think this is the first presentation that I've heard that sort of discussion. I guess like what are the conversations looking like for clinicians like in that clinical space of using LLMs and how it might be more climate friendly?
Yeah, it's still a very early conversation. There's very few people talking about it. But we're trying to, through our FAMIA working group, we're trying to bring more attention to it. And I think it's not so much at the level of individual clinicians yet, but really hospital leadership. Because if you look at like health system leadership right now and some of their big priorities, implementing AI across the board is a huge thrust. But also health systems have signed sustainability pledges. In 2021, at the start of the Biden administration, under HHS, the Department of Health and Human Services, there's an Office of Climate Change and Health Equity that was created. And this office, along with the White House, created a health sector pledge for health systems to pledge to reduce their greenhouse gas footprint. The US healthcare system is responsible for about 8.5 to 10% of our total greenhouse gas emissions. And globally, if you look at emissions from healthcare systems globally, the US is responsible for 25% of global healthcare emissions, despite only taking care of 4% of the world's population. And so there's a lot of, over 200 health systems have signed these pledges to reduce their greenhouse gas emissions by 50% by 2030 and to get to net zero by 2050. And one of the things, and similarly, big tech as well, like Amazon, Microsoft, Google, all the big tech companies, since their LLM strategies have come online, have all said their energy use is spiking and they don't think they'll meet their targets by 2030. So that's kind of like the higher level conversation that's happening. And I think in many ways, like the big tech companies have said, like, we're prioritizing our AI business goals over our sustainability pledges. And I think health systems have an interesting role to play here because of the purchasing power and trying to align these two forces of sustainability and AI.
Let's on Zoom. Rita, do you want to go ahead and try again?
Yeah, could you hear me now?
Yes.
Okay, good. So very interesting talk, and I have a question. So I particularly focused in when you were talking about you know, the diversity issue, but also the idea of patient activation as an outcome or time. So we have a study now that patients are able to download all their data, but they're able to review it, which is part of the OpenNotes, right? And they're also asked to add data if there's missingness and correct data if there's mistakes. And we do this before we run risk prediction models after so it's integrating the data from the EHR and the patient-derived data. And we're currently in a position where we want to be able to allow patients to have these corrections or additions put back into their electronic health record. So my question is, with OpenNotes, I assume that there are things that patients see that they don't agree with or they want to add. Could you give me an idea of what the current state of that is, like writing back to the EHR patient data?
Yeah, definitely. It's such an important point because that process of patients being able to request corrections, amendments is still a very manual, often broken process. So I'll say, so OpenNotes doesn't work directly with any patients in the context of care of their information. We are just a research group, basically. And we don't develop any of our own technology or practices, just work with health systems on providing advice. So we'll just say that. So we're not necessarily directly working with the health system and trying to figure out what that communication process should be like. That said, I will mention, I know there have been some companies in this space that have tried to address this. There's a company called Unblock Health that was started by Grace Cordovano, who's a really strong national patient advocate, actually based here in New York. And Grace, and yeah, the whole premise, I don't know exactly, and it's not an endorsement of the company, I don't have any personal stake in it, and I don't know exactly how well they're doing, but I do know it really started with this question of the fact that patients' requests to amend their records oftentimes don't make it all the way through. They don't get to the place where that documentation change happens because it's this very manual process. I think in this world of AI written documentation, I think it's interesting because we may have more avenues. Like, for example, if we keep the recording from the original conversation and then also have the pre-note and then the final note, there may be just more tools in place to go back and request a record correction. But right now, also many of the companies that do ambient scribing, they are not necessarily keeping that audio transcript data, I think, after 72 hours. But that's kind of maybe looking towards the future. I think one other issue too that often happens is that when patients try to contact a health system about issues in the records, you're usually going to HAM, like Health Information Management, medical records, which is not your clinician. And within a lot of health systems, the process of like how HAM communicates to frontline clinicians to then change their note, it's a very clunky. And I think that's often a place that really slows things down. So I think it's great that you're exploring that. But those are some of my kind of initial thoughts on it.
Thank you.
Yeah, this is a really interesting talk. I had a question kind of towards the beginning. You brought up the fact that the rollout of AI technology has been like kind of a lot faster than previous new tech of its time. And I feel like that's like it's mirrored in non-healthcare sectors as well. Like everyone's racing to kind of start implementing and allowing it to the general public. And considering how sensitive healthcare is, in the best case scenario, we could just like keep it in a focus group and perfect the technology until it's out there. But in your opinion, what is like the most important aspect that you'd be focusing research or debugging on before like in order to protect patient like care quality and privacy, just safeguarding things like that? What is your number one priority?
Yeah, it's a really good question. I think in the world of like predictive models where, you may have like an image AI tool that's reading an X-ray and coming up with something, I think the work around understanding bias and how bias gets embedded in models is really important to understand and be more transparent about. And I think with predictive models, we do have like a better process with the FDA and how those get evaluated. And I know there's work on things like AI, like nutrition labels. I think all of that is still really critical. I think in the world of generative AI, really large language models being implemented for communication, it's a bit of the Wild West right now. I think the most important thing, because we're in this period of like rapidly rolling things out without a lot of deeper understanding, I think there should be a lot more transparency. I think, for example, when health systems use AI to pre-write a message to patients, even though a clinician is reviewing that, I personally think that that should be disclosed. And so I think it's important to prioritize the transparency, because in a way, we're all kind of working on these systems together. And then I think the other aspect of it too is, there's a lot of people who are excited about how this technology can fix broken paradigms, right? Like there's this huge clinician burnout epidemic. And on the one hand, and part of it is clinicians feel like they don't have enough time to actually talk to a patient and listen, and patients feel like their doctors aren't listening to them. The AI technology, if you use well, could actually help free up more time and allow for deeper conversations. But at the same time, the business interests of the healthcare system could say, hey, if you don't have to spend as much time documenting, you should see 20% more patients, which may lead to increased burnout. And so I think there's this broader question of the potential of AI to really transform healthcare to the way we'd like it to be. And I think we're in this unique, because it's a new technology, there's this unique opportunity window where we can try to, change the system a little bit, but at the same time, a lot of entrenched interests with a lot of financial interests will also try to, maintain that status quo. So I think, I don't know if that's getting exactly what you're talking about, but it's those are some of the bigger pieces I, would say is important to think about.
We have time for one last very quick question on Zoom. Jenny.
Yeah, so thank you for the interesting talk. I'm a first year PhD student. I have a psychology background, so I'm really interested in what you've mentioned about use of OpenNotes in mental health, like psychotherapy. So I wonder, could you share a little bit more about that? Like, I'm also interested in like the privacy issue. How could you make sure the notes are kept between patients and clinicians, especially for like adolescents? I'm assuming that their parents can access to the notes.
Yeah, really, really important question. On the mental health part of it, there's been a lot of studies of that access to the notes. I'm not an expert on those, but if you go to opennotes.org and look at the research section, there should be a section on mental health notes and research. And if you can't find it, just shoot me an email and I'm happy to connect you with those studies. But I know that there's been a lot there. On the matter of the adolescent privacy piece, that's an area I focused a lot on. The issue is with the access to notes is primarily through the patient portal. But patient portals have a lot of different configuration variables. And so for adolescents at most health systems, usually when they turn 12 or 13, depending on the state, there's a separate change in settings where their parents may not be able to access all of that information. But different health systems implement that in different ways. And documentation is particularly tricky because it can combine multiple types of information, where, for example, you maybe have a 16-year-old girl who is coming in for diabetes-related care, type 1 diabetes-related care, and has information about insulin in the medication list in the note. But then they also want to talk about something related to reproductive health that they don't want their parents to know about. And that information can be commingled, and we don't yet have great, there aren't really data standards to separate that. There have been efforts to do this. There's a group that I was a co-leader for a few years called Shift that's working with the ONC and EHR vendors to create better data standards. for sensitive information. And then all of this has really been heightened since the overturning of Roe v. Wade, because you now have this variability where care in one state is actually illegal in another state, and it's leading to all sorts of issues with information exchange. So yeah, it's a huge topic, and I think it's one that unfortunately doesn't get enough focus and attention because a lot of the kind of safeguards that are needed often cost more resources. And so I think we've been behind in developing those, but there are a lot of people working on it. Thank you.
Thank you.
Thank you so much for coming. This was fabulous.